Good afternoon, everyone. Thank you for joining us. It's 3:15. We'll get started. Thank you for coming for the updates from the Family-Centered Care Guidelines. My name's Jody Mullen. I'm going to moderate at the beginning today. I'm a clinical nurse specialist at UF Health Shands Hospital just up the road in Gainesville. And then I'm joined by my second moderator here on my left, Lauren Liebrecht. She is a physician-trained research scientist from the Department of Surgery, and she comes to us from Virginia Commonwealth University. Our first presenter then, Dr. David Hwang, is a professor and chief at the Division of Neurocritical Care at the University of North Carolina in Chapel Hill, North Carolina. He is also the co-chair of the writing group that put out the most recent family-centered care guidelines in adult ICUs, which are just hot off the pressers. And he is also a previous recipient of the Grenvik Family Award for Ethics. Following him will be Carrie Sona, and she is a clinical nurse specialist in the surgical burn trauma ICU at Barnes Jewish Hospital. She serves on the ethics committee at her hospital and has an interest in communication, end-of-life communication, and she also was honored with the Grenvik Family Award for Ethics just this past year. Yay, we have good people on the stage. And finally, Dr. Mekela Whyte-Nesfield joins us. She has a pediatric background as an associate professor at Children's National, and her research focus is on PICU-associated child and family post-traumatic stress disorder. So we have a great, excellent faculty here. Join me in welcoming Dr. Hwang.
Thanks so much, Jody, for the introduction, and thanks to each of you for making the time to attend the session today. It's, I think, the peak of Congress. I was looking at the app, and I think I counted there must be like 7 or 8 different sessions going on at the same time, so you certainly had quite a few choices, and we appreciate the fact that you attended this one. We hope that the talks will be ones that stimulate you, and we're looking forward, hopefully, to some time at the end for some discussion as well. For this first part of this session, SCCM is pleased to announce that we have a new set of updated family-centered care guidelines that were just published in Critical Care Medicine. And so we'll spend about the next 10 minutes or so just providing just a big overview of what the guidelines show. We won't go into each one by one, but the hope is to talk a little bit about how we put them together, the motivation for doing so, and then talking a little bit about how they differ from other sets of guidelines on the same topic that SCCM has put out in the past. So with that, these are my disclosures. And as I mentioned, one of the great things about SCCM, and I suspect that many of you in the room might feel the same way, is that the society has a long history of prioritizing patient and family-centered care and really promoting it amongst our profession. As I mentioned, these set of guidelines that we're talking about today are an updated set. There's actually been 2 sets of guidelines on this topic that have been published over the past 20 years or so. Both of them were led by Judy Davidson out at UCSD. And just to go through the history of it a bit, the first set of guidelines that she and her team put out actually really was conceived about 20 years ago or so now. And that initial set of guidelines, which you see on the right-hand side of the screen, was, when you read through them, you'll see that it's an expert panel. It reads like a narrative review, a detailed narrative review of different topics related to family-centered care. And the authors graded the evidence that they saw based on a sort of Cochrane methodology, and then released 40 different statements in that guideline related to different aspects of promoting family-centered care in the unit. When this was updated in 2017, which you see on the left side of the screen by Judy and by her partner, Randy Curtis, rest in peace, they actually pitched this new set of guidelines as not so much an update, but a totally new set of guidelines. And the reason for that is that they use an updated methodology for that 2017 guidelines. I think most of us in the room are familiar with the grade methodology that we might take for granted now when we're reading SCCM guidelines. But 2017 was the first time that the writing panel put together a set of guidelines for family-centered care that was based on this grade methodology. So fast forward to last week. We're pleased to talk today about the updated set of family-centered care guidelines from SCCM. I wanted to spend a little time just up front just highlighting members of the writing team, the writing panel, and just to really express thanks. So I'll first start by saying that I had the pleasure of co-chairing this writing panel with Mona Hopkins from BYU. And we had a great set of vice chairs for the writing panel with Rebecca Askelson and Giora Netzer. Just a few more shout outs. We certainly could not have done this without our methodology team. Those of you who have worked on guidelines before know how much work it is. More about that in a second. But I'd just like to thank Simon Oskowski and Kim Lewis, who's here too, for the amazing amount of work they put in to the screening and the abstraction and the evidence review for these set of guidelines. I see Ruth Kleinbell here as well. There may be others in the room who were involved. I want to give a final shout out actually to two members of our panel. That's Christian Ferrier and Theodora Peters, who were our patient and family representatives, which are important for any set of guidelines, but certainly for this set. So just to give a brief overview, I won't go into the nitty-gritty of the methodology because they're pretty similar for most sets of guidelines, but just a few things just sort of up front as we go through things. The previous two sets of guidelines that I had put up there from SCCM, they were really broad in terms of their scope. They covered not just adult ICUs, but pediatric ICUs and neonatal ICUs. And when we put in the request to update these guidelines for this most recent iteration, SCCM asked us to keep ourselves to 15 PICO questions to really sort of try to make these guidelines a little bit more compact and readable. And so we made a decision up front, even before we started a literature review, that this set of guidelines would be primarily focused on adult ICUs, really just out of practicality for trying to make follow the new SCCM guidance and make the guideline more readable. So as I mentioned, we had 15 PICO questions that we scaled down and that we talked about as a writing panel. I will say what makes this particular set of guidelines made them interesting to work on and maybe a little bit unique compared to some of the other guidelines is just the breadth of outcomes that are included in these types of studies. So there's all different dimensions, several different dimensions, I would say, of different outcomes to any study that's looking at the impact of family-centered care in an ICU. You have family outcomes, right? Things like family symptoms, anxiety and depression, family satisfaction with care, family impressions of quality of communication. That's a whole dimension in and of itself, right? And probably the most important, I would say, for family-centered care guidelines, but not the only dimension, right? There's the patient dimension. There's our traditional outcomes that we think about, mortality, functional outcome, quality of life, but also patient symptoms of anxiety, depression, and so forth. There's clinician-related outcomes, like what are the impacts of these different interventions that we're testing on each of us who work in the ICU. The pandemic only highlighted the importance of some of these outcomes, like work stress and burnout. And then finally, relational outcomes. And by relational, we mean relationship between those of us in the room, different clinicians, and the family. And primarily, these are things like promoting or not promoting family trust and a relationship, between the clinicians and the family. So we took a look at all those different outcomes. There's quite a few, I would say. We did go through the traditional voting process of voting as a panel about which of the different outcomes in each of these different categories was most important. But I will say, as we sort of go through some of these recommendations, what we decided to do was, in the interest of making the guideline readable, we simply stated the recommendations that they are without specific outcomes attached, simply because so many of these are multidimensional. I didn't put this on the slide, but I'll say up front, so back to Simon and Kim's team who did the evidence review. But they reviewed, I believe it was 27,000 abstracts. 27,000 abstracts were screened by their team at McMaster, and then we actually ended up including 550 studies, about 550 studies or so, in the actual review. So, Kim, I hope you're not having PTSD right now. Sort of, a little bit, We should study the methodologist's outcomes with these guidelines, I think. But it was an enormous amount of work, and so we're proud of the result. We had 15 PICO questions, as we said, and so our guidelines, when you take a look at them and download them from the website, you'll see there are 17 statements that are attached. So the 17 statements, we divided them into 4 different categories, similar to the prior guidelines. And so the broad categories: engagement of families, support of family needs, communication support, in support of ICU clinicians providing family-centered care, which we thought was particularly important to highlight post-COVID. So as I mentioned, what I'll do is I won't go over each of them in order. What we'll do is we'll sort of mirror the executive summary that was published with the guidelines. I'll talk a little bit about two of the guidelines that are different, I would say, that have differences from 2017. We'll talk about the guidelines that are quote-unquote new, and then talk about those that are old, and sort of frame things that way. So let's talk about two that had changes from 2017. The first was in the category of family engagement. And I'll just read out this recommendation out loud. We recommend liberalized ICU family presence policies as the default practice in ICUs. And the difference here is, the 2017 guidelines advocated for open visitation policies, but for those of you that read those guidelines, you'll know that all the guidelines in that set were conditional. And we just wanted to highlight for this particular set of guidelines, this was the one recommendation in our set that came out that we updated from a weak suggestion to a strong recommendation for a number of different reasons, both for the evidence and for the importance of it. With regards to the evidence base for liberalized family presence policies, our team reviewed, I believe it was 8 different randomized controlled trials evidence that looked at this question of liberalized versus restrictive family presence. We use the words liberalized and restrictive because when you look at the different trials, some of them are not necessarily testing strict open versus strict closed, but different variations, like different degrees of liberalized versus restrictive. Probably the most major randomized controlled trial that came out a couple years ago was from the Brazilian group, the ICU visits trial, which was a trial looking at 1,000 Brazilian patients. It was a cluster randomized trial where they randomized patients to restrictive versus liberalized family presence and in ICUs. And their primary outcome that they were looking at was delirium, which they weren't able to show difference. But the study was a very rich one with all that data. And they found for a lot of family-centered outcomes, things like anxiety and depression, family satisfaction, that they showed that liberalized family presence was able to move the needle. What you see on the screen here is just one snapshot of our meta-analysis for, we did a number of different outcomes. The one that you see here on the screen is for family satisfaction with care. And with that Brazilian visit study that you see that's listed as ROSA 2019, and the rest of the observational evidence, along with the other randomized controlled trials with other outcomes, we felt that the strength of the evidence lent us towards making a strong recommendation for liberalized ICU family presence. And on top of that, I would say, I would just say up front that the experience of all of us post-COVID with the way that COVID impacted family presence policies in our units and how even with the pandemic, quote unquote, being over, that these policies sometimes may still linger depending on which institution you're at and where you are in the world. I'd be really curious to hear during the discussion what your own experiences have been where you are. But we felt that based on our experiences as a field post-COVID and with this randomized control evidence, that we felt comfortable in 2024 updating this to a strong recommendation. The other recommendation that had a major change, I would say, from 2017 was one in the category of supportive family needs, and that's specifically with regards to decision-making support tools. I'll just read this out too. We decided as a panel to make no suggestion, to have a neutral recommendation for or against any specific decision-making support tools for families of ICU patients. In 2017, if those of you who have read them and recalled, in 2017, those guidelines actually did suggest a recommendation in favor of using such tools. The evidence, as they outlined in 2017 at the time, was mostly quasi-experimental studies, like non-randomized before and after studies. But since then, since 2017, we have had a number of randomized controlled trials. The most major of which was Chris Cox's study from his team at Duke and his collaboration, where they tested a decision-making support tool for families of patients who had been mechanically ventilated for 2 weeks. And for those of you who are familiar with the study, you'll know that they were not able to show their difference in outcomes with prognostic concordance and anxiety and depression. They were able to show in their study a small improvement or a small difference in decisional conflict between those families that were randomized to the intervention versus not. But what you see on the screen here is the decisional conflict meta-analysis for our guidelines. And with the additional studies that were included, we felt overall that the analysis itself did not show definitively that decisional conflict was reduced. And so with this, this is not to say that decision support tools should not be used. It simply means there needs to be more work, to understand what do the tools look like, how should they be deployed, what are the right outcomes to study. So I think there's more on this to come. But we did feel that in terms of following the science, that the best scientific statement would be to have a neutral recommendation. Those are the two major changes from 2017. I'll talk about a few new conditional recommendations in our 2024 guidelines compared to 2017. We suggested offering family participation in the bedside care of adult ICU patients. And for a few of these, I underlined adult because the 2017 guidelines for some of these specifically made recommendations for neonatal ICUs or pediatric units. For example, for family participation, the 2017 guidelines focused on neonates. But we felt that we had the evidence to make a conditional recommendation for participation in the bedside care for adult patients. Similarly, identifying and supporting the mental health and psychological needs of families of adult ICU patients. Providing general bereavement support to families of patients who have died. The 2017 guidelines focused on providing a bereavement support brochure to families of loved ones who are passing away. And for this set of guidelines, we decided, based on what we saw, to not hone in on a particular way of bereavement support, but to support general bereavement interventions as a whole. And then finally, structured programs to support clinicians in promoting the delivery of family-centered ICU care, which again we thought was very important in light of what our whole field went through in COVID. I'll note that these last two that I mentioned actually harken back to the 2004, 2005 guidelines a bit. That they were there, but were left out 2017, and we felt that they were important to bring back. Finally, one of the new recommendations we had, but which was a neutral recommendation, was one of no suggestion for or against specific tools relevant to family-centered ICU care. So what does that mean? We're talking about tools that are for the clinical team, that are meant to help promote family-centered care from the clinical team perspective. So things like family-centered care checklists or protocols that people form. Again, this isn't to say that your unit shouldn't utilize a checklist or a protocol. It just means that from a grade perspective, we weren't able to find the evidence to support any one particular tool that would impact an outcome of importance one way or the other. We had one new best practice statement, and when I say new, I guess what's new is old, what is old is new again. We recommended that ICUs implement practices to systematically identify and reduce barriers so as to promote equitable critical care delivery for patients' families. And the barriers that were highlighted in our literature review are things like language, varied cultural understanding, beliefs, and expectations around critical care delivery. When I say what is old is new again, these weren't included in 2017. But if you go back and read the original set of guidelines from 2000 that were started in 2004 and published in 2007, there's actually quite a nice section in there about making sure that we deliver culturally competent and empathetic care. And then finally, just to highlight a few of the conditional recommendations in our new set of guidelines that mirror what is from 2017 and what was from 2007. I think many of these will hopefully ring true for those of you in the room, but offering families the option of being present on ICU rounds, offering family presence during resuscitation, which has a good body of evidence, providing family educational programs, providing ICU diaries, standardizing approaches to family meetings and facilitation, providing communication skills training to clinicians, and in particular, one thing we highlighted in this set was trying to have high fidelity or like simulation type training for trainees with regards to communication in the ICU, supporting spiritual needs of families, and a best practice statement for incorporating supportive ICU design features. Just to wrap up, I'll mention that there were a few PICO questions from 2017. As I mentioned, we had to not addressed in the new guidelines based on space restrictions, but it doesn't make them any less important. So these include the important roles, the obvious roles of nursing and social work, anything related to end-of-life care, so palliative care, comfort care protocols. These were in the 2017 guidelines, but it's my understanding that SCCM is putting out a new set of guidelines specifically focused on end-of-life care. So we decided to hold off on that for this set. And then finally, the importance of ethics consultations, which were highlighted in 2017, but which we left out. Just in terms of making these guidelines practical, I just wanted to highlight, similar to 2017, the team at SCCM was wonderful and put together an implementation toolkit that you can download from the SCCM website that helps your unit, if you're part of leadership and you're trying to figure out what to address first out of these 15 guidelines, helps sort of guide like what to do and how to do it. So there's a gap analysis toolkit that you can download that goes through each of the different guidelines and allows you to rate how often your own ICU already follows these recommendations. It's accompanied by this prioritization matrix where once you sort of highlight those that have room for being done more frequently in your unit, you can kind of prioritize based on which of them seem most addressable in your local environment. And then finally, there's a whole set at the end of practical work tools, things that are available on the internet, things you can download so you don't have to reinvent the wheel. If you're trying to figure out how to address one of these recommendations, you can go to this work tools document and get a sense of what's out there already. I'll just end here, I think, just by saying you can find these new guidelines. They're published. They're available in critical care medicine, but also through SCCM's website on the guidelines webpage. And with that, I just want to thank a few people. I thanked the writing panel already. We clearly want to thank Judy Davidson for just her vision and her just being a pioneer in this field. We had other patient and family representatives involved in this work who, because of the reality of being chronically critically ill, couldn't see it through the whole project. But Rhonda Jackson and William Longa were two family members of patients who helped us as we got things off the ground. Kim and Simon's methodology team, again, I cannot express enough like how much work they did and the amazing quality of the work they did. We wanted to thank Maureen and Mark for being our representatives on from the ACCM Board of Regents. And we had a team of folks who actually worked specifically on the implementation tools I mentioned at the end, led by Dan Woznica at SCCM, Jose, Andrea, Peter, and Roberto as well. And then finally, just a thank you to Hari Ali. I don't know if you're here today, but if you are, just thank you so much from a staff perspective, keeping this whole thing organized. So that's it for me. We're looking forward to your comments and questions. I'm going to pass it on to Carrie now.
You can't see me. I'm too short. Hi. My name's Carrie Sona. I am a clinical nurse specialist, like she said, and I have no pertinent disclosures other than I was asked to talk on this topic 2 weeks ago, and the topic given to me was shared decision-making and navigating to optimal patient outcomes. The other disclosure is that I learned about the new guidelines when I walked in here and met the moderator today. I'm very well versed in the 2017 Davidson guidelines. We've done the analysis at our institution, prioritized, implemented all of the gaps that we had. So I'm glad to see they're not markedly different, but I was not aware of those when I made my slide set. And then the other one is I really love Taylor Swift. So that's my disclosures. All right. So the case that I'm going to open my talk with a case, and again, my talk is about shared decision-making. So we had this is a real person who was in our unit in December. A 70-year-old, unknown, past medical history gentleman who he was driving his 18-wheeler and he struck a fence at about 30 miles an hour. He was hypotensive in the field. He was hypotensive when he got to our emergency department. He got some blood and FFP. They found that he had a ruptured infrarenal AAA. The operating surgeon put a note in his medical record that before he took him to the OR that said, I have seen and examined the patient on 12/13/2024. I agree with the findings and plan of care with the following modification. 70-year-old male came in as level 1 following an MVC. In discussions with him, he developed back pain immediately prior to the crash. I had an expedited discussion of endovascular repair with a marginal neck. I discussed stroke, renal failure, possible need for hemodialysis. He was agreeable to temporary dialysis, but absolutely refused permanent dialysis. No written consent was obtained due to the emergent nature. So they took him to the operating room. They repaired his AAA with EVAR. At the end of the case, he had really high peak pressures, and they required a decompressive laparotomy with an abthera temporary abdominal closure. Post-op in our unit, he had ongoing resuscitation, and unfortunately, he had endoleak and required re-exploration. And guess what? He needed temporary hemodialysis for hyperkalemia and lactic acidosis. So the patient had agreed with the surgeon in the ED that he would agree to temporary hemodialysis. He had no family presence during that time. They came in after his operation. He was intubated in the ICU post the endoleak repair, and his family said, absolutely not, no way. He would never want that. His wife of 35 years, who was his durable power of attorney, his adult children said, absolutely not. The ICU attending, the ICU fellow, and the attending surgeon all felt that, in their professional opinion, it was survivable. They didn't have a crystal ball, but Captain Jack said, according to his family, that if he could not ride his motorcycle, he would not want to live. Again, because of the medical team feeling so strongly that this was, he knew that he may need it, they got an ethics consult, and they consulted a hospital administration. That, again, the surgeon felt very strongly that the patient understood and agreed to it, and so that's where I'm going to leave the case. And then I'm going to talk a little bit about shared decision-making, but I will give you the cliffhanger at the end. All right, so shared decision-making, what is it? So a central tenet to shared decision-making is that patient self-determination is a desirable goal. It's a goal that, as healthcare workers and patients, we work together to make decisions. It's based on healthcare workers giving what they know to be the most, the pros, the cons, the costs, the benefits, with all of their knowledge and experience to align what care with what the patient's values and preferences and emotional state and perceived capabilities are. Shared decision-making hopefully allows us to have people play a role in their decisions that affect their own health. And again, patient capacity is requisite. And when there is no person, the patient has no capacity, that surrogate decision-makers are used to help make those decisions. Other things about shared decision-making, it's found that decisions that are based on personal preferences are more likely to be adhered to, with improved outcomes and less regret. And I point out bullet point number 2, they're useful for non-emergent decisions. Clearly, the case that I opened with was an emergent decision, so often shared decision-making isn't best determined at that point. Implementation does require actual structure and process. You can't just wing it. You do need to have some thought. I can't remember your last name, the physician Dave, who spoke first, said that in the new guidelines that the use of tools are that they're not necessarily mandatory, but it does help sometimes to use them as reference materials to help explain things or help have patients and families understand. I will say also, knowing and lived experience are very different things. If any of you have ever had a family member who's had medical care or received medical care, I had a knee reconstruction from a mountain bike crash, and according to my orthopedic surgeon, my knee is good as new. I should just be able to mountain bike and do everything. That I can tell you my knee is not. My lived experience is very different than my surgeon's perception of my reconstruction. So those are very different things. There are toolkits available, and now there's a new implementation for patient-family guidelines in the patient-centered care guidelines, patient-family care guidelines, but the National Health Service has them and the AHRQ. The shared decision-making was endorsed by the Patient-Centered Outcome Research Institute in 2017, and again, these are common sense. Benefits are that hopefully patients and families will have improved knowledge, patients will have that, more realistic expectation, lower conflict, more people that are active in their decision-making, less people who are undecided, and greater agreement between what our values and our choices are. And as mentioned, outcomes are difficult to measure. They're often complex, and they often happen over time, and very often measured by patient satisfaction scores. There are different approaches that I think are very practical. I'm going to do the healthcare workers first, and we always do this at end of life. best case, worst case, most likely. There's a lot of educational videos that we use to train caregivers that I do think it's practical. Tell me the best thing that could happen, the worst thing, and what do you think's going to happen? And then there's the share model, which I won't go through each of those. And then the one that I find that I think is helpful for patients and families is the BRAN, the ask for questions. What are the benefits, risks, alternatives, and next steps? So if they're engaged in thinking about those, at least you're going to have the conversation and know, and not just one person with knowledge, not sharing it or even thinking to communicate it, because I think a lot of times healthcare workers are caught up in the, it's no big deal, we do this every day, and you don't think about asking people what they want or what they value, and if you're not asking those questions, you're never going to find out, and then there's not alignment between the healthcare team and the patients and families. So engagement strategies, again, common sense, family-centered rounds, which, yay, high marks in the new guidelines, and you can come in whenever you want, wonderful. And then there's other things called the CUS program. Again, this is not rocket science. Dignity and respect, make eye contact, use plain language, have decision makers identified, get all the stakeholders in the room, have family meetings, listen and invite questions, share information, and use teach back. I want to make sure that I explain the pros and cons. Can you tell me in your own words about the risks and benefits? Barriers to it, a lot of people say, it takes so much time, but if you take the time on the front end, hopefully you save time on the back end. Others are that the healthcare workers are not actually very well trained in providing information to patients and families. We have a paternalistic medical model in many cases. Some people have low health literacy. Some cultural backgrounds really aren't, they don't really have a tradition of autonomous decision making. And then just the areas we worked in, they're busy, they're hectic, there's a lot going on, there's no privacy. And I already mentioned the time that it takes to have good conversations with people. So again, it's a balance of common sense. You have to sort of deal with the situation that you're in to apply the right solution. So should we always do the same thing? Absolutely not. But it should always be patient-centered. And then in some situations, it may be better if the provider-driven approach is more practical, ethical, and efficacious. And I'm just going to quickly tell you something that I think I said earlier, that shared decision-making doesn't happen by accident. So we have a format in our intensive care unit that we do around advanced care planning, because I think I have a passion for end of life, and I think it's something that's often not spoken about early enough or universally. So we have a meeting once a week. It's intentional, it's quick, it's efficient, it has the right people at the table, and we want to make sure that we don't miss high-risk patients with high-stakes poker conversations with our patients and families. It takes an hour, and we run 36 ICU patients through in an hour. We have me, the CNS, the attending, the fellow, the social workers, case managers, and anybody's welcome to attend. This is the template. I won't go through it, but it's a screening tool that we use to help identify high-risk situations. Do we think the person's going to die? That's the first question. Is there family discord? I try to identify those things. Is there other staff pain points? Are there other family issues? And then we try to get a palliative care consult early. We try to make sure the note is documented in the electronic health record so it's not a secret to the only lucky people who got to be present for the conversation, so everybody knows what's happening. Okay, so that's my end on shared decision-making. I will give you the end of Captain Jack's case. So he returned to our unit post-operatively. As I mentioned, his wife, he went back. They were refusing dialysis. They made him a DNR. And then the ethics team reviewed the case and deemed that while Mr. Turner did verbally consent to, I didn't mean to put his name in there, sorry, that given his pain and hypotension, he may not have had the capacity to make that complex decision. And his wife, and it was his durable power of attorney, it was decided that she was able to carry forth his wishes, and he was transitioned to comfort care. And I will again point out that was not necessarily shared decision-making, and the surgeon's nuance in his conversation with the patient may be different framed because he did want to help the patient. The patient had a life-threatening condition that in that moment, he was saying, I can help you, I can fix that thing. So potentially you can't have a very high-level conversation always in that moment of emergency, but later upon reflection, you can parse out what the patient's wishes are and desires and long-term outcome based on how things are going. Again, the goal of shared decision-making is to create a shared understanding between the healthcare worker and the patients and families to make sure that we get care right. And I'm going to read this quote directly. The model of delivery may be different for each situation, but shared decision-making is not another thing that clinicians must do. That is to help patients select the best evidence-based option given their preferences, but that it is a method of care as central to the clinician's art as history-taking, the physical examination, the selection and interpretation of diagnostic tests, and patient education and counseling. Thanks for your attention. I'm going to hand it over to Mekela.
Okay. Good afternoon, everyone. Again, thank you for being here for this most important conversation. So I'll be talking a little bit about dealing with contrarian mindsets and oppositional personalities, particularly for us as healthcare practitioners, dealing with families and patients. I have no disclosures, but I do want to give an honorable mention to Dr. Tessie October, who is a palliative and critical care trained physician who was very instrumental in this talk, both from a mentorship perspective and from the content. So when we talk about the contrarian mindset, we're going to kind of go into what that means for us and then explore how healthcare as it is today within the United States and a lot of the world motivates oppositional behaviors and how it potentiates these behaviors in our patients and their families, and then really look into some guidelines and mitigation strategies for when that occurs. So the first thing is we think about a contrarian as someone who's going against the prevailing trends, not just with fashion, but with everything. And then they're expressing an unpopular viewpoint, and probably the hardest thing for us as providers is telling us that we're wrong. However, we fail to notice that in medicine and in many things, contrarian behavior is really questioning widely accepted truths, and that's usually how we find new truths, where we weren't looking before, advancing the field to where we are today, and we'll continue to do this in the future. So why do our patients and families challenge our recommendations? Well, as someone who's never been on the side of the patient-physician discussion as the patient when things are not going well, I can still say that healthcare systems are scary, both as from myself and for family members. When you are dealing with someone who's critically ill, there's fear that comes about that may make you act differently than you would, and it perpetuates the initial lack of trust that is pervasive in our healthcare system from the people that we care for. Now, that doesn't mean that because there's that lack of trust that we can't form good bonds, but we have to understand why that lack of trust is there. And part of it has to be with things that are in the media, but a lot of it has to do with the history of healthcare in this country, especially with marginalized populations. When we think about someone who is ill or family members of someone who is ill, there's a loss of agency. So agency is thinking that you can affect change, you can affect the outcome. And for a lot of the people that we care for, the illness has taken that away, where they feel this sense of lack of control. And then we're dealing with a healthcare system with multiple different levels of providers, multiple different opinions, all trying to come together, sometimes not very effectively, with one voice to the patient or their family members. And if I want everyone to think about a time where they had a family member who was very oppositional or who said to them, well, the other doctor said something completely different, and how that would make you feel when you do not have that sense of control to affect change, and you're trusting someone who's telling you something different from the person you trusted 10 minutes ago. We also have to think about, that brings into the fact, well, what if they're wrong, right? As practitioners, have you ever felt like, wait, maybe I'm wrong? When things are not going well, or when you're not sure of a diagnosis, Has that ever entered your mind? And then think about not knowing enough or not knowing what you know, and things are not going well or things are going differently from what you expected when we talked about the risk-benefits ratio. And does that ever make you feel, or would you feel like, what if they're wrong? And lastly, and very importantly, is multifactorial decision. When I look at a patient in a bed who's not doing well, and I look at their family, I'm seeing that patient as they are now. But their family members are seeing that patient as they were 10 years ago, as they were yesterday, what they value, the joys that they have, the sorrows that they have, how they've walked in life. And that can breed a decision that is very different from what we are making. Take in context our patient who would take dialysis for a little bit, but not for life. And his family's like, I don't think so, because that's not how he walked in life before. And so we have to think about how that lays into the collaborative agreement we're trying to make with our patients and their families. So in every equation, are we the ones fanning the flames, or is it just from the patient side? And so there are definitely things that we as practitioners do as a whole that makes this situation a little bit difficult. One is the use of complex language. What are we actually saying? So in talking about this with Tessie, we discussed a patient who's had glioblastoma. In a family meeting, the neurosurgeon said, your child has glioblastoma. The oncologist said, your child has glioblastoma, and went on talking about it. 20 minutes later, mom looked up and said, wait, Jimmy has cancer? Totally missed the whole thing for the first 20 minutes of the conversation, because we're using language that is not necessarily familiar to everyone. It's very familiar to us, but not necessarily to the people that we're serving. And thinking about that, it also means that we are ignoring their narratives, right? If someone walks in and English is not their first language, or they're in a very stressful situation, which is how we tend to encounter them, their mind may not be necessarily where you're speaking, even if they would have known that word normally. And so it's important to think about who we're speaking with and their story and how that puts them within our conversation. When these two things come together, it also forms the other sides of our stars, which is the paternalistic approach and exclusion from care. So one is the physical exclusion from care, right? We're resuscitating your mom. You're not allowed in here. Can someone please escort her out? Versus, this is what we need to do to save your mom. And both of those can kind of fan the flames of how someone is looking at the situation and how contrary they're going to be. One is the exclusion of, exclusion breeds, we don't actually know what's happening. Sometimes information is not shared at all, and sometimes when it's shared, it doesn't actually sit with meaning. And then the other one is, you're telling me what to do, but I feel like there may be something different, or maybe there's something you're not telling me. So how do we approach these as a preventative strategy within medicine? So one of the things when we talk about how we communicate with our patients is enhancing our communication skills. So this is one model. There are many. This is just one that I like. So really asking for permission. Is this a good time to have this conversation? Are all the stakeholders, like we talked about before here, present, that we can have this conversation and have it be a meaningful one? And probably the most important one is, tell me in your own words what you've been told about what's happening with yourself or your loved one. That really gives you some insight into what they know. It can be a jumping off point to continue the conversation. It could also give you insight into clarifications that need to be made. And most importantly, it gives you language that the patient and their family are comfortable with for moving on to the next important step, which is talking to them about what is happening. And so we talked already about the type of language that we use, but also reflecting their words back to them. So Jimmy has a brain lesion. Jimmy has a brain lesion that is a type of cancer that can be, or is known to be very deadly. Then we continue the conversation. So I just said, is known to be very deadly. That has message. Does it really have meaning? I'm not so sure. It doesn't really tell the family how long they may have with Jimmy. It doesn't tell them what that process is going to look like. And that brings on to, when you're talking with a family, message and meaning. So yes, we have a brain cancer that is likely to be deadly, but during that period, Jimmy may lose his ability to walk, talk, eat, things that are basic joys that we take for granted that would be very important to know as a caregiver taking care of Jimmy. And then I want to know, really, how are you going to relay this to the rest of your family if you had to? And that's one, giving them language if they need to do that. Usually we like to ask to do that, take that off their plate if we can. But if they needed to do it, it gives us some insight into how much they understood, and again gives you an opportunity to provide clarification and make sure that that message and meaning was carried forth. So how do we elicit patient, and family narratives? So I love listening to stories. I don't know about everyone else in here, but one of the greatest joys I have found is feeling like I actually know the person laying in that bed. And whether it is, do they have a specific nickname that they like to be called? At one point, we had a patient who had passed away from a brain bleed, and we were about to remove the ventilator. And Mom said, hey, he really loved roasting people. He did it every year for Christmas. He made a video. It was very funny. And we said as a team, do you think that's something that you would enjoy doing, that would bring you closure? Most people would be like, why would you want to roast the dead child? But for that family, it brought some sense of closeness and closure. And it was something that they were allowed to videotape, and they have for forever. And that's just, if you don't know a patient's narrative, it's very hard to have a collaborative agreement that really aligns with their values. Invite the village. We talk about opening the doors to family members to be present. These are the people who have held this patient up for most of their life at important moments, at hard times. And yes, you are very important, but to them, you may not be the most important person in the room. Lead with empathy. So we all can understand when patients and families are going through difficult times, but we've never walked in their shoes fully. And so while we can understand, it's more important to be empathetic to realizing that you don't fully know. And so we talk about it being a difficult time, also being open to listening to what exactly is making this even more difficult than we might be imagining. Sorry. So when we talk about including patients and families in care and decision making, this kind of falls into what we were talking about with the new guidelines, which I was happy to learn about today. But even more so, talking about the presence during resuscitation. And that's something that has been brought up by families as an opportunity for them to be involved. But for clinicians, there's been a lot of work looking at it. It's seen very differently from clinician to clinician. And therefore, there has been some data looking into family presence during resuscitation. There was adult systematic review in 2023 that found that looking at 500 and plus patients, they found that not much studies have been done with this topic, and given that they were not able to make any strong recommendations for where we should be sitting on this topic. But in pediatrics, we have a lot more data that shows that no harm is necessarily brought to the patient, and there may be about moderate benefit to the family members being able to be present. And I want to bring it back to what we may be getting for benefit when we look at the data. So one of the things was really that if a family is going to be present, they can't just be present, they have to be present with support. And that needs to be someone who's able to look at the situation and walk them through what is happening, what they're seeing, what they may be hearing. And a lot of us talk about, well, that could potentially put my patient at risk, it could put my code bay at risk. And you definitely want to set boundaries as to where the family member can be, and the boundary of if they're not able to stay there and not potentially interrupt the code situation, then they will need to leave. they'll be removed. And most family members are open to that once it's phrased as this is for the benefit of your loved one. And then we think about family members seeing like what can be a really ugly situation, lots of blood, lots of gore, and how do they feel about that, and whether that increases traumatic responses. And what we found is that families appreciate the opportunity to be present, and it gives them the opportunity also to opt out of some procedures or care moves that they may not want for their loved ones, and redirection of care in the moment. So there are definitely benefits and risks with every situation, but for what we found, there is an balance towards more benefit to family members in this situation. Team members on family-centered rounds, there's also been some work done on that in terms of the opportunity to be involved when their whole team is there and to ask questions if willing. That is really family dependent. Some families do not enjoy it, and some do. And so it's important to have the opportunity, but not all families will engage. So lastly, we want to talk about strategies of establishing collaborative approach. So we think about eliciting values to be able to make recommendations. It is really hard to help guide family members with shared decision models if you don't understand their values. And like we spoke about a little bit earlier, that's going to take some time. But really it is getting to know what is important to that family member that is ill, and asking the family member who's the caregiver, would it be okay if I make recommendations now that I understand your values? And it's important because sometimes we feel like we have to do everything. The family's saying, yes, I want everything done. But do they really understand what everything means and what are the risk factors of the harm that can come to their family members with this everything umbrella? And so knowing values of, well, yes, I want my family member to have a long life, but I really want them to not suffer. Is probably a word that's used a lot, or to endure unnecessary pain if it's not going to change the outcome. And then we can have a real conversation about how CPR is painful, potentially, and what it does to the body if we're not expecting a result of saving a life or any meaningful recovery. Within that, you're going to have to explore some emotions. It's going to bring about a lot of emotions for the family and sometimes within yourself. And so it's important to, one, be grounded in your ability to be open to discussing emotions with the family and being able to guide them through what they're really feeling. So that contrarian anger sometimes that we see, is that really just an angry person, or is that fair? And what are they scared of? Do they not want to be sent home on hospice because they don't want their loved one to die at home and they need help with that, or they don't really understand what hospice services will look like? And those open up opportunities for information sharing and for a more collaborative approach. So in light of all the recent things that have happened within the healthcare system, and we've had some tragedies recently where healthcare members have been hurt, we want to talk about de-escalation strategies. And so the first one I want to talk about is when to give to patients and family members. One of the things that we really lean into a little bit is, do we need to be strong, head fast in our recommendation? Do we really have the evidence, as we were speaking for, to support what we're recommending, or is it just the standard of care that we kind of give out as a blanket statement to everyone? If not, and the recommendation would not give harm, would it be therapeutic alliance to fold on that recommendation and meet the family where they are? And I like that example of the dialysis because, yes, we think that we can help the patient, but really if we are not thinking that he would fully recover and it may cause harm to his way of life, are we doing something that's just good for us, or is it really for the family and the patient, and how do we bridge that gap? And then when we hold, when a family member is asking for something in this everything umbrella, is it something that's going to cause harm to the patient, and do they fully understand the consequences of what they're asking? And then Within the communication umbrella, we want to talk about setting boundaries. So one of the things that I have been taught with setting boundaries is when we have escalating parents within the room, escalating voices, where you as a human being are just not functioning as well. You ever have someone just screaming at you? I don't even know what they're saying to me anymore because I just see the screaming. And being able to be like, I really understand that this is a difficult situation for you. So validating the emotions, I understand that you're angry and I want to help, but I can't focus on what you're saying to me because you're yelling. Can we bring the volume down so that we can work together to find a solution to the issue? It does not always work, hands down. That does not always work. And if you feel unsafe in your body, I have done things like leave the door open. We've all done the, please call me in 5 minutes if I'm not out. But sometimes that's like a real rescue that's necessary. Go in with another provider. All the things that we have to do to try and remain safe within our work is really important because we're here to help the patient, but we want to make sure that we can go home to our families as well. And then there are de-escalation teams. I'm not sure if every hospital has them, but they can be really helpful for, sometimes you just need another face. Sometimes your face is associated with something for that family and they cannot get past it. And so whether it's a social work team that comes in to help de-escalate, an ethics team, another practitioner, whatever it is, that's part of your de-escalation team, that you want to lean on them when things go awry and you need a little bit of a reset. Thank you so much.